Well, hello and welcome to this Urgent and Emergency Mental Health Care Summit. It's so good that this is taking place. I'm really sorry that I can't be with you, but it's brilliant that you're working together internationally to try to set standards and establish principles for the best possible emergency and urgent care. I wanted to spend a moment or two just speaking about why I think this is so important. For me, the importance of the principle of equal treatment of people with mental ill health is really vital. Too often people with mental ill health are still treated as second-class citizens, and I felt very much as minister that there was no area where this was more apparent than in how someone gets treated in the middle of an emergency. And for me, the sort of basic principle has to be that whatever your health emergency, you should get the same access to treatment and of course evidence-based treatment and support that's appropriate for your circumstances, not a one-size-fits-all approach. And so what I started to work on was the need for the setting of principles and standards nationally. What I witnessed as minister in terms of this sort of sense of people being treated as second-class citizens was, at that stage, still thousands of people ending up every year in police cells, for goodness sake, in the middle of a mental health crisis. People, when they did get access to emergency mental health care, being shunted around the country in search of a bed, a practice that I think is abhorrent in the modern age. It would never happen to someone who'd suffered a stroke, after all. So why do we tolerate it for people who experience a mental health crisis? Particularly when we also take into account the fact that for people who are sent out of area, there is evidence that there is a higher risk of suicide when someone emerges from inpatient care. I was also conscious of other practices, such as police cars turning up at someone's home and an individual being taken off in a police car in the middle of a mental health crisis. The person who brought that to my attention was Frank Bruno, who came to see me when I was minister in the Department of Health, who described to me how when he was sectioned at his home, several police cars screeched to a halt outside his house. And he said the sense of embarrassment and shame was palpable, that he felt that any neighbour watching would have thought some awful crime had been committed. And in fact, he was ill. And so it's completely inappropriate to be using marked police cars for someone who is ill rather than for someone who's committed a criminal offence. These were the sort of things that drove me to believe that we had to set some standards and some principles. And so I met with Home Office officials, I met with police, senior police officers and others, and I proposed to them that we should work on what became known as a crisis care concordat. In other words, getting everyone to sign up to a set of principles that we could then seek to apply across the country. That process took some time to work through, but we got to a point where we got agreed principles which everyone signed up to. We published the Crisis Care Concordat nationally, and then we said to every part of the country, we want you to sign up to these principles, and then we want you to work on how you could apply those principles locally. So I felt that that was the right mix of national leadership but local power to decide how those principles should be applied. What then happened was that it was in the run-up to the winter period, and the Department of Health was about to disperse a substantial sum of money to the NHS, to every locality, to deal with winter pressures. And I persuaded the Secretary of State that we should require that every area should sign up to the principles of the Crisis Care Concordat as a condition for receiving winter pressures money. And wonderfully, that concentrated minds and ensured that every area signed up by the deadline that we'd set. We then set another deadline to say, by this date, we want everyone to have drawn up an action plan. So again, it's up to the local area to decide how it's done, but just do it. Set a plan for how you apply those principles in practice. And again, because I think we built a sense of a moral imperative, we got everyone to commit to doing that. And in time and by the deadline, every part of the country had signed up, and we had a map online of England, and bit by bit, as each area of the country signed up and then in turn produced its action plan, that part of the country turned from red to green. And there was this sense of a building momentum, and I think also a sense for those areas that remained red that they were behind the curve and that they had to get their act together to catch up with other areas. And it became almost, it was, as it was described to me, a social movement of change, and something that people felt proud of and quite excited by. And so I think the way we did that ended up working rather well. But I think then implementation of those action plans and sticking with it becomes critically important. There is an awful sense that things happen in Whitehall. You have the minister pulling levers to make things happen in the department, and then you discover the levers aren't attached to anything. That's a sort of typical sense that ministers have in government, particularly in now quite a decentralised NHS. So you cannot just assume that it's happening across the country. And so you have to maintain, I think, that sense of national leadership and an accountability in every area to make sure that things happen as they should do. And that we accord with people's human rights, that people's human rights are respected, that there is equal treatment, no second-class citizens, and that people get access to the best possible and most appropriate care. I should also mention that as part of the whole approach to the Crisis Care Concordat, we were also developing the idea of street triage, and this is the very simple idea of police and mental health services, particularly mental health nurses, working together collaboratively, sharing information, sharing learning and understanding, so that when a crisis occurs, it's not the police, without any training dealing with that crisis. There's an input from a mental health nurse. In rural areas, sometimes it's by telephone. In more urban areas, it can be a car with a combined team arriving at the location. But I think that informs much better practice with the police. And of course, if you can deal with the problem on site, if you can help someone to relax and calm down within their own home, then that's so much better than an inpatient admission if it's achievable. I wanted to say something about prevention. Prevention both of crises, but also the idea of suicide prevention, which is, of course, so closely linked to this. I think ultimately we only deliver a good, civilised mental health system if we focus on preventing those crises from happening in the first place. And I want to see as an overall objective quite a significant shift of resources from what I would regard as still too often institutional care to crisis prevention, support in the community, preventing a deterioration of health if it's possible in the first place. Just as by way of example, the Care Quality Commission in the UK last year identified the fact that we have 3,500 beds in what are wonderfully described as locked rehabilitation wards. Now, I don't begin to understand how you can deliver rehabilitation in a locked ward. And the Care Quality Commission was making the point that there are very many people in those wards who are capable of living independently without being locked up in an institution. Now, if you think about it for more than a moment, this is a pretty fundamental breach of people's human rights. When I talked to the Care Quality Commission, what they revealed to me was that we're spending nationally something in the region of £800 million a year on those locked rehabilitation beds. So what better as an aspiration, a vision, than to move away from that model of care. Of course, when someone needs to be in a bed, they must be in a bed, but to shift resources towards better prevention, better support in the community, preventing those crises from happening in the first place. Tim Kendall, the National Clinical Director, in his work in his own trust in Sheffield, specifically set about trying to repatriate people who've been placed in out-of-area placements, often in institutions a long way away from home, often private institutions charging an enormous amount of money, bringing them back home, at the same time looking at the length of stay and recognising that often length of stay doesn't bear any relationship to good clinical judgment. People get trapped too often in inpatient care. And so they managed to reduce their length of stay at the same time as repatriating people from out of area. And they were able to close beds and reinvest the money in the community. Now that's the sort of shift of resource and culture that I want to see. And I think in that way, you end up with much better crisis prevention and much better use of resources. I wanted to say something now about suicide. In a way, there's nothing more important than saving lives. And the awful death toll from suicide is something that I think should focus the minds of all of us. I speak with some personal experience. My own sister, Catherine, my oldest sister, took her own life about 2.5 years ago after a period of intense clinical depression and after having been a voluntary inpatient for about 10 weeks. And she was kept as an inpatient on the sort of basis of a risk assessment. But ultimately, after discharge, she ended up taking her own life. And I'm left thinking, was there not a better use of that resource? A lot of money was spent on her care, but enabling her to re-establish links with her neighbours, her friends, her other social contacts, rather than an inpatient stay, which I suspect wasn't very therapeutic. It was in a dull and unattractive inpatient unit with obviously a lot of very troubled people. And so again, this focuses our minds on how we better prevent crises happening and how we better prevent suicides from happening. But the whole principle of zero suicide, which I find so attractive, is the idea, first of all, of an audacious commitment, a moral imperative that we seek to save every life, but critically combining that audacious commitment with the application of evidence. We have a lot of evidence now about how we can prevent suicides from happening. And that, of course, centrally involves much better preventive care, getting early access to psychological support, for example, for people with long-term physical health chronic conditions, people who suffer from stroke, from diabetes, from breathing conditions, so often experiencing psychological problems, but without the support that can help them cope with those very big challenges. So I'm a very strong advocate of the zero suicide movement, and I would encourage all organisations to sign up to a commitment to zero suicide, not as a target, but as an audacious challenge to the organisation to seek to save every life and then apply the evidence. So let me just conclude by making this point. I think that we need to combine policy, setting principles, setting standards with how services actually operate. And we have to have that national leadership, but local inspired leadership to make sure that those principles are applied in practice and then maintained. And we must never assume that that will happen. It only happens by a concentrated focus on maintaining those standards, maintaining those principles. So thank you so much for coming together for this really important conference. If we apply the learning from this conference, we have a big impact on people's lives, and indeed, fundamentally, we also save lives. Thank you very much indeed.